how did dentistry get this moniker? How did it get this reputation for being pain? I mean, you don't say that about the eye doc or the foot doctor, or you only say that about dentistry. Why? How did dentistry get this bad name? And the reason I think, in my opinion, is I don't think we've done such a very good job in treating dental pain all these years.
Hello again, everyone. Welcome back to a bonus episode of A Tale of Two Hygienists podcast. My name is Andrew.
And my name is Michelle.
So for those new to the podcast, each week Michelle and I bring on an amazing guest from the dental world who fills our nerd brains with new insight or affirms our clinical abilities.
And we are so grateful for the time and effort these guests put into making us better. We also wanted to acknowledge that this episode is powered by Crest Oral-B, and this episode wouldn't be possible without them.
And we know you guys are going to really enjoy this episode.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast R.P.H. and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
So we have an amazing guest with us today. Mm-hmm. He has been speaking all day long, and
Thank you for being here.
I'm glad to be here. This is just an outstanding feeling for me right now to be back in my hometown in New York City.
Nice.
And being able to speak at the Greater New York meeting is always a treat. So I love it a lot.
Yeah. And so this is Tom Viola?
Viola. 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 Either way, doesn't matter.
How does your mother pronounce it?
Viola.
Viola.
Like the instrument, yes.
Viola.
Exactly.
All right. And that's how we'll go with Tom Viola.
Yes.
So maybe, we talked a little bit about maybe doing a pharmacology series. Pharmacology is obviously your passion, and we would like to hear a little bit about your background, and let's just jump right into pharmacology.
Sure. Sounds good. I've been practicing as a pharmacist for 30 years now. I graduated from St. John's University in New York City, so again, born and raised here in New York. Practiced for a long time, and then got a job as a teacher in a school in Pennsylvania for pharmacology for dental hygienists. Loved it, never looked back. I'm still teaching at that same school all these years later, and 14 other schools. So I'm at 15 schools altogether between spring, summer, and fall.
Nice.
I enjoy it.
So you got a job teaching to dental hygienists first?
Correct. Right.
Yeah.
For pharmacology to dental hygienists.
Yeah.
I loved it so much that the teaching bug, when it bites, it's a pretty strong bite. So I started branching out to other schools who needed someone to teach pharmacology. Word just spread. And now I teach mostly the hygienists. I do from time to time teach the dentists as well if they need me. But it's much more of a rotation thing, in dental schools where they kind of swap in and out faculty. When I'm in the hygiene schools, I love it because it's just me and them, and the one-on-one is great.
Nice.
I enjoy it.
So where do we begin?
You want to talk about pain control?
I would very much like to talk about pain
Is
control.
that the most common?
It's probably the most common question I get is how to best treat pain. And the reason for that is dentistry especially, like no other profession, is so tightly intertwined with pain that in many cases, in my opinion, they're inseparable. So when people say, dentistry, what's the first thought that pops in your head?
Ouch.
Ouch, pain. It's
Root
going
canal.
to hurt. Yeah, it's going to hurt. It's going to be bad. And so how did dentistry get this moniker? How did it get this reputation for being pain? I mean, you don't say that about the eye doc or the foot doctor, or, you only say that about dentistry. Why? How did dentistry get this bad name? And the reason I think, in my opinion, is I don't think we've done such a very good job in treating dental pain all these years. And if it's not us prescribing the pain relievers the way we should, it's the patient perhaps not taking them the way they should, or not taking them for as long as they should, or not the right combination. So the first thrust I have in any of my presentations or any of my classes that I teach in the schools is, what is pain and why is dentistry so heavily involved? But pain in dentistry is different than what you find with most other pain. Most of the pain, orthopedic pain or any other kind of pain you experience, gets really bad in the beginning. So if you bang up your elbow, the greatest amount of pain you're going to be in is at that moment. And that over time, it's going to get progressively better and feel better over time. That really does two things. Number one, it solidifies that you have reached your threshold. Whatever your pain threshold is, you're at it. And it's only going to get easier and better from here. The other thing is there's this sensation of, well, the pain's going away. I'm getting better. I'm healing. Dental pain is the exact opposite. It starts out not so bad and gets progressively worse over time. And so since that's counter to everything you know about pain in your whole life, there's this feeling of, okay, it's not getting better, it's getting worse and worse and worse and worse, and I'm starting to get anxious and fearful because it's not fitting the norm. It's not fitting the way things are supposed to go. It's supposed to be getting better. It's getting worse. Now, when I sort of use the analogy of as being on the roller coaster, you know, when you're on the roller coaster on the way up, the greatest fear you have is you don't know how high you're going to go and where's the drop. And that's the same thing with dental pain. When you're on that roller coaster heading up, you don't know how bad it's going to get. You knew before with your elbow, it's already that bad and getting better. Here, you're getting worse and worse, and there's no telling how high that pain is going to go, how bad it's going to get. And that is probably the single most greatest source of anxiety for the patient, and which is why patients associate pain with dentistry, because they remember being in pain. The greatest thing you can have to form a memory is emotion. So if you think about any memory in your brain that sticks out the most, I'll bet that memory was tied to some type of emotion, good, bad, or otherwise. And so when you're in pain, you remember, because it's a negative emotion and it's a strong emotion. The fear, the anxiety, you remember that and you take that with you.
Yeah.
Every time you go back to the dental office, you take that with you. So I tell my students a lot that it's when you're in the operatory with your patient, it's the three of you. You know, it's you and the patient and the 600-pound gorilla sitting in the corner. The gorilla's name is last time, right? Because the gorilla comes with you every time you go to see the dentist or the hygienist. That gorilla comes with you. And the minute the hygienist or the dentist or anyone in an office does anything to make that patient experience any kind of discomfort or pain, the first thing that happens is the gorilla gains another 100 pounds, and you remember, oh yeah, that's right, this place is where they cause pain.
Yeah.
And honestly, we can do a better job of treating it if we just use the right combination of analgesics and in the right order. We can not only treat pain, we could eliminate it in the first 24 hours. And that would reverse the whole thing. That would make people think, you know what, that wasn't so bad last time. I might go back again, and this time go back sooner.
Are you talking about doing something prophylactically to help kind of control the pain during the moment, or are you talking more about like post-operative pain control?
Both. That's the problem. We don't do enough prophylactic and we don't do enough post-operatively. Patients experience pain because they produce their own pain. We produce these substances called prostaglandins. These prostaglandins are trapped in all of our tissues. When you damage tissue, you release those prostaglandins, and that triggers the pain and inflammation. Well, if that's the case, then the easiest way to treat pain is to get rid of prostaglandins. But how? Well, you need a medication to do that, and the best medication of all to treat that kind of pain, to eliminate prostaglandins, is ibuprofen. Most folks take ibuprofen when they feel pain. But the problem with that strategy is, as my professors told me so many years ago, was what? That the best way to treat pain is to take a prophylactic dose, because by the time you feel dental pain, it's too late.
So when we're talking prophylactic, how could you do that if you don't know you're about to have a toothache or an infection? Is this more like surgery or therapy or treatment?
It's a good question. So you're going to start the prophylactic pain control before the procedure. So you know you're going to go see the dentist or the hygienist that day. You start with a prophylactic dose of ibuprofen or Tylenol before you get there.
Okay. So we're talking more like coming to the dental office, not like I just blew up with an abscess, kind of prophylactic.
If you feel that abscess coming on, if you feel that first tingle and you know things are bad, start taking your pain reliever right away.
Yeah. Do you ever experience or hear things where patients like overdo that? They're like a little bit works, a lot works better kind of mentality?
Yeah.
From the prophylactic standpoint?
All standpoints. You know, the thing is, as I often tell my audiences and my students, the medication we use to treat dental pain is the medication that eliminates those prostaglandins, and that's ibuprofen. Ibuprofen is our greatest friend in dentistry. Many people can't get past this, though, because they don't understand. Can't we do better than Advil? There's nothing better on this planet than Advil to treat such excruciating pain. But the point is, no, there is only one, and it is Advil, and it is our best friend in treating dental pain. Okay, so when should I start taking it and how much? Okay, so we've covered that part. We said take it as soon as you feel the pain and take it before you're going to have that dental procedure done. But it's the how much that becomes the problem, because we need to use a device with ibuprofen, a construct, to use the most ibuprofen we can without using too much. The problem with ibuprofen is it's a slippery slope. You want to use enough to eliminate the prostaglandins, the bad ones, the ones that cause pain and inflammation. But taking a very high dose of ibuprofen eliminates other prostaglandins that are good for you, like stomach lining and bronchodilation and clotting. And that's where a lot of us get ourselves into trouble. We take a lot of ibuprofen. More is better. So we take that 600 milligrams, but 800 milligrams, thinking we're going to get better pain control. But what we end up doing is knocking out not only the bad prostaglandins, knocking out the pain, but also knocking out the good prostaglandins and causing all these side effects. So the sweet spot for ibuprofen is really 600 milligrams.
I've always heard that.
It's always been 600, but most folks think, well, 800's got to be better. More is better. And so that goes from us to patients to just about anybody who's ever taken ibuprofen. It's seemingly, so benign. It's such an easy drug to take. Well, why not take a little extra and get more pain control? But that doesn't work for us, and that's why, unfortunately, we suffer more side effects than we need to.
So, and to eliminate the good prostaglandins, is that one dose of 800 milligrams? Or is that I need to take multiple doses before I start?
Good question. Does
Taking
it
out
build
those
up,
good
right?
ones.
Does it? So the point is you want to take 600 milligrams as one dose, 3 Advil, right?
Yeah.
As one dose, and take it routinely. So once you start taking it, you keep taking it. So you start, I like to say 90 minutes prior to the procedure. The reason for that is the sweet spot of ibuprofen is about 90 minutes from the time you take it to the time it actually starts working very well. So start 90 minutes before and then just keep going. Don't stop. Right through the procedure, right through that day, that first 24 hours at home, you just keep taking it. But the issue is, I take ibuprofen, makes me feel good. I don't want to take it anymore. I'm fine. And you fall behind. And then once you get behind the pain and you don't stay out in front of it, you're really chasing the pain the entire time.
For sure.
So by the time you feel pain, it's too late. Start early and keep taking it and don't stop, at least for the first 24 hours.
Are there other considerations for, Michelle's tiny, I'm large, would I need a bigger dose or would she need a smaller dose ever with ibuprofen?
Ironically, no. For most people, despite their size, the same doses work. I could see if you were sort of slender, you may want to take a little less, but you got to be careful because there's that sweet spot with ibuprofen that if you take less based on body weight, you may not get the sort of pain relief you're looking for. So we try to stick with 600 milligrams. The good news is we're only going to use it for 3 days. In dentistry, if you're still in moderate to severe pain after 3 days, something went wrong.
Something else is wrong.
And so you need to be reappointed to be seen because something's not right. Most people tolerate pain and do pretty well, and most people are out of pain within the first 24 to 48 hours with the type of analgesics we're talking about, at the doses we're talking about. Beyond that, if you're in pain 72 to 96 hours later, I think we've either missed something, as far as disease is concerned, or we've not used the medications correctly. We need to switch off to something different. But I'd be hard pressed to think it's the medication. I think it's probably pathology.
So in your recommendations, so for example, as hygienists, a lot of our procedures are going to be maybe like the scaling and root planing, deeper cleaning type situations. But there are some patients also that come in and they don't really have the periodontal issues, but they have really sensitive teeth.
Oh, yeah.
Is there a difference between that type of pain and maybe I'm going to go way down to the gums and stabbing gums kind of pain?
I think ultimately a lot of folks experience that kind of pain and can't differentiate it anyway. All they feel is this sensation of discomfort. So whether it's that stabbing pain, or whether it's just because they got some extraction done, or deep scaling done, there's just a level of discomfort that they're not happy with. So we need to use ibuprofen to treat that pain regardless of what the origin was. I think they could probably do less days worth if there was just a scaling and root planing. Maybe 24 hours would be necessary. They might need more if it was an extraction or a root canal, but it's still the same medications as always. However, ibuprofen is not the only medication. It's one piece of a cocktail that you should be using really to treat pain. And I can say this because while ibuprofen is a great drug for treating inflammation and even fever, when it comes to treating pain, ibuprofen is not enough on its own. You've got a great anti-inflammatory in ibuprofen, but it really doesn't do very well as a pain reliever. So what do I do in this situation? I add a great pain reliever that really doesn't do well as an anti-inflammatory. So it's the combination of ibuprofen plus Tylenol.
And
That
I
works
thought
well.
that was a no-no.
Oh yeah, if you ask Dr. Google, he
Yeah.
or she will say, you can't do that, you'll die.
I'm actually,
But-
this is funny because this is what I did when I had the flu, and I was like, I don't care if I die at this point. I'm going to do
Already
this.
dying.
Exactly.
How much worse could it
But
be?
it was the only thing, and I alternated them. So look, I guess you're going to tell us more about that.
Well, when you treat fever, you want to alternate because the two medications work synergistically. So they work by treating fever from different avenues, different ways of handling the fever. Pain control, though, you'd want to not take them in alternating doses. You want to take them together.
Okay, so
And-
I was doing that wrong. Then.
Well, if you're treating pain, you
Okay,
do them
okay.
together.
But
Fever is
fever, you
alternate.
can alternate, yes,
Right.
yeah.
Fever alternate, but pain you want to take them together. And what that does is, since both of them work from different mechanisms of action, they work much better together as synergistically than even if you were to alternate. There was this thought process a long time ago that if you alternated ibuprofen and Tylenol, it's good for treating pain because as one was cresting, as one was getting, the greatest pain relief, one was on the way down, and so it's kind of like a sine wave. But we've discovered over the course of time that it's much better to just take them together and capitalize on that synergy, but take them every 6 hours. Now, if you add up the dosages, that gets to be a little scary for most folks. It's 600 milligrams of ibuprofen. Okay, that's a lot, isn't it? 4 times a day. That's a lot, isn't it? That's 2,400 milligrams. But the upper limit of ibuprofen is 3,200 milligrams. So you're well within the 2,400 milligram limit. Unless, of course, during the patient's medical history, the patient says something like, well, I take a lot of Advil PM, I take a lot of Advil cold and sinus, then I can see maybe worrying about the dose. But just plain out, taking it for dental pain, 600 milligrams 4 times a day is not too much. What about the Tylenol? Okay, well, Tylenol gets a little risky. The FDA has said in the past that the maximum amount of Tylenol you can take in a day is 4,000 milligrams. That's been reduced now to 3,000 milligrams. How do I get 3,000 milligrams of Tylenol? And that doesn't seem like a lot. That's essentially 6 extra strength Tylenol. I could take that in a day very easily. And so we recognize that. So most of the studies that have been done that have said to mix ibuprofen and Tylenol together say to use 650 milligrams of Tylenol. And I don't think I'll ever tell a patient to do that. The reason is because as a pharmacist especially, I know human nature and I know what it's like. They'll go to the pharmacy and they'll buy or think they're going to buy regular strength Tylenol, 325 milligrams each, and take 2 to make 650. But 4 inches away, they're going to see extra strength Tylenol on the same shelf and say, I don't want regular, I want maximum. And take the maximum strength Tylenol.
Yeah.
But now they'll take the 500 milligram tablets, take 2 of those as 1,000, and take 4 times a day. They've just blown through the daily limit for Tylenol. So I tell them to take 500 milligrams of Tylenol and 600 milligrams of ibuprofen and caffeine.
So caffeine, like the reason that we see Excedrin with caffeine?
Exactly. So caffeine is an analgesic adjuvant. So it, in technical speak, it increases the analgesic effect of other analgesics. But in dentistry, it plays a particularly important role because it's a vasoconstrictor of large blood vessels. By vasoconstricting the large blood vessels in the tissue, that allows swelling to decrease, which allows the smaller blood vessels that feed the tissue to dilate and keep the blood flowing. The greatest problem we have in dentistry or any type of procedures that are done on very sensitive tissues like the oral tissues is swelling. We don't often see oral swelling. It typically is hidden in the tissues, but it's there. And swelling causes compression on those blood vessels, which stops the blood flow. Take caffeine, which helps shrink those tissues, and the blood vessels can pop open. So it's sort of counterintuitive how it works. It actually works pretty well to decrease that swelling and increase the blood flow to the tissues, and that helps the tissue heal. That helps the tissue respond better to therapy. And again, we're only dealing with 24 to 48 hours, so the faster we can get that going, the faster we can get blood flow to that tissue and get that tissue to heal, the better. So it really works very well to add on the caffeine. The problem with adding caffeine is, again, how much. You know, I'm not talking about Starbucks. That's sort of like rocket fuel. All right, we want to try to get to more benign doses, like 50 milligrams of caffeine, like what you'd find in an average can of Coca-Cola, or what you'd find in a regular brewed cup of coffee, that sort of thing. If you don't like caffeine, you can substitute something like dark chocolate with cacao, you know, with theobromine, right, which is sort of the same thing, or even green tea, you know, whatever works best for you. But the point is low doses of caffeine, so you're not jittery, but just enough to get that vasoconstriction and that blood flow you're looking for.
So would there be a tablet to take that's a caffeine version that would be better or do anything differently?
Yeah, so you could also do no-dose tablets, which are 100 milligrams each, and break one in half.
Okay.
And get 50 milligrams. You could do that too, absolutely. You would think that with this cocktail being so effective, 600 milligrams of ibuprofen, 500 milligrams of Tylenol, and 50 milligrams of caffeine.
Someone would make one.
Somebody would just make one, yes. And they do. It's in Australia. So that's the only place you can find it. It's not here in the U.S.
Oh, we'll be there next year, so let's stock up.
Stock up and then
Let's start on black market.
You going to the International Federation?
We are.
I'll be there too. So
Oh,
I'll see you next
sweet.
year. Yeah, I'll see
Great.
you
We'll put some in your suitcase.
Melbourne. I'm going to bring a bunch home. Yes, absolutely. I'll probably get stopped by customs, but that's all right. Whatever.
Like, wait, what was my limit? Oh, 20. I thought 200.
Do you have something to declare? Yes, I do.
That I'm going to go through because I got to take myself.
That'd be fun, and we'll do another round of this for sure.
That would be awesome, yeah.
But
I'd love it.
there's gonna be a large contingent of U.S. people going to that.
I'm looking forward to it. Yeah,
So
it's going to
we'll
be
have a lot
great.
of our friends there.
I got really lucky. I got to do an hour session with Joanne Garanley, and she's awesome.
We love Joanne.
We adore her.
Yeah, she's just amazing, and so I got really lucky that they picked our course. So
What did you? You're going to do an hour-long session with her? Or
Yep.
You did. Okay.
we're going to do an hour long. So it's 2019. It's in August, right?
August, yeah.
And so we're going to do, I believe it's an hour long session on cancer.
Well, let's go ahead and sign up for that.
Yeah.
Yeah, like we
I
just
think
need
it's
to
great.
get on that.
I'm going to love it. She's just the best to work with. Joanne's just awesome. So
Smart, so
yeah.
smart.
I got really lucky.
Genuine.
Yeah. Okay, so they don't make those tablets here.
They don't make those tablets, so somebody's
don't.
going to be taking 3 Advil,
3 Advil, 1 extra strength Tylenol, and caffeine of some kind.
50
whatever
milligram
caffeine.
dosage
Yep.
of caffeine.
Right. And that's going to make that whole combination work much better.
So they could take that and just chug a Coke.
They could. Absolutely. I wouldn't know if I'd do that 4 times a day, though.
Yeah, I know.
I might do the Tylenol and ibuprofen 4 times a day. I don't know if I
All
would
of
do
a
the
sudden, I
caffeine.
became a diabetic. I don't know what happened.
And tooth decay, like terribly.
Yeah, I'm like
And I
this
can't
tooth pain.
possibly get any rest because I'm wired from all this caffeine. I totally get it.
Yeah. Yeah.
If this is the best recipe, when would this not look so positive and you would need to bring opioids into?
Right. So if this works so well, then I don't need opioids. Well, many studies have suggested just that this combination of non-opioid analgesics works so well that there's no need for an opioid. I don't agree or disagree with that. I think I'm sort of middle of the road. I think there is a place for opioids in dentistry. And I think, when you're on that roller coaster ride and you're on the way up and you don't know how bad it's going to get and it gets progressively worse and you're just in agony, an opioid is what you need to essentially pull the plug, to just stop the ride, let me get off for an hour or 4 hours, whatever, and just sort of regain my control over the situation. That's great. And that's what it's used as a stopgap. I completely agree. But what's tragic is when people use opioids as their sole means of treating dental pain. Because dental pain is mostly inflammation, and there's nothing anti-inflammatory about opioid analgesics. So as a result, you're treating the symptom, but you're not treating the cause.
So Tylenol 3.
Tylenol 3, codeine, Vicodin, Percocet, all very good at pulling the plug, again, used as a stopgap to stop the ride I want to get off, but not necessarily for treating pain. Then you're not treating pain, you're just merely postponing it. And the problem is when you postpone it and don't treat it, it comes back, which means you need to take another one, and another one, and another one, and that's how the ball starts rolling. So I've often told patients, if you're going to take an opioid analgesic, take it, but be advised, while you're taking that opioid, you're still taking the other analgesics to actually treat the pain. So that when the next dose comes available for that Vicodin, you may not need it this time, or maybe you only need 1 or 2 more doses because you're on the mend, you're on the way of treating that pain.
Or, I mean, I was just trying to think of like all the possible scenarios that this could come about, whether it's, the prophylactic, you're going into because you feel like a little tingling of an abscess coming on. Well, then we are going to treat it through endodontic therapy or a filling or whatever needs to be done for that particular situation. Just trying to think if there's another pain situation that.
Well, in our world, I'm thinking scaling and root planing, but not really for an opioid need. I mean, and I come from surgical background, so implants, and personally have had jaw surgery, so I was a real fan of the opioid the first day or two.
I'm sure, yeah.
But you've definitely seen the patients. We've always pushed the ibuprofen, right? Like, do this first, or maybe stay with the opioid on the first day, but taper yourself off and keep with the ibuprofen is kind of where we were for a very long time. But never have I heard the Tylenol combo. So this is great.
Yeah, so no alternating, take them together.
Yeah.
And I have to say that there's a significant part of the opioid piece that we're missing if we don't talk about it now, which is the opioid script itself, whether it's electronic here in New York State or anywhere else. That opioid prescription serves 2 purposes. If it's filled, it serves the purpose of relieving pain. But even if it's unfilled, it serves the purpose of acting as a placebo. It's control. I'm in control. If it gets really bad, I'll get that prescription for Vicodin filled, and I know it's going to work.
That's true.
But if I don't get it filled, I don't want them in my house, I have kids, whatever, I don't want them in my house, fine. It's still available to me. That's, I think, the mistake we make in dealing what we call the opioid epidemic. We think we shouldn't prescribe them at all. I think that's doing a disservice to our patients. They should get prescribed an opioid and leave it up to them as to whether or not they take it. And believe me, as a pharmacist, I can tell you many, many times that prescription just was, put that on file, I'll let you know if I want it. But that's okay, because it still represented a placebo. It still represented control. At any point, if this gets really bad, I can take care of it with this opioid.
This concoction's not working.
Exactly.
I have a second.
I have a
backup
backup
plan.
Absolutely. And that is, I think, the greater value of the opioid overall. So I'm not a fan of us not prescribing. Can you get away with not prescribing opioids? Sure. Ibuprofen, Tylenol, caffeine work out 7 days a week. But I think an opioid has its place in dentistry.
Is there a recommended amount that maybe should be prescribed so that, let's say that 3 months later, I'm not really sure how long these prescriptions are until the expiration date is for them, but then maybe I'll just get this filled now just to use it because I went out and played soccer and banged up my knee or whatever.
Yep, I think a lot of people used to fill prescriptions for opioids to keep them around just for that. Like, I used to call the friends and family plan. Like, you keep opioids in your medicine cabinet for your friends and family, whoever needs it.
Right.
But a lot of people now, I think, especially since the opioid take-back days have become so popular, every couple of months, or I think it's twice a year, I think, where the DEA sponsors these take-back days. You bring your opioids to get disposed, and a lot of people just say, well, why would I get the script filled? I don't want them in my house anyway. So they don't fill the script. But most prescriptions for controlled substances like Percocet and Vicodin are Schedule II substances. They're only good for 30 days from the day they're written anyway. So it's really no one's going to end up filling them anyway after that 30 day. That's why it's better to leave it at the pharmacy, let the pharmacist keep the prescription on file. If you need it, great. If you don't, it expires, and it's all good after that point. I encourage most dentists to make sure they only prescribe no more than a 3-day supply, because you don't need more than that in dentistry. So the most I'll ever tell a doctor to write for is 10 tablets. And you're going to use it 3 times a day, and you're going to write on there, as needed for severe pain only. You sissy, or something like that.
I was going to say, can I punch you in the face? That is a 10. That feels like that.
And this is not. A little flick is
little
love tap.
That's not.
Yeah, I mean, you don't need more than 10 tablets, and you don't need to take all 10. You don't have to take any. If you took 1 or 2 in the first 24 hours, if that was enough to cover your pain, fine. So 10 is more than enough. Again, after 3 days you're still in pain, I want to see you again anyway to reevaluate. Opioids as a placebo and as a pain reliever, awesome. Non-opioids in this cocktail, as we described, also is awesome. But bottom line is, how did all of this lead to where we are with the opioid epidemic? How did we get here from where we were, let's say, 15 years ago? And the bottom line is, people ask me all the time, why are opioids so popular? And the answer is because the endorphin release is so great. Many people have said to me over the course of time, people I know who because I'm active in the community, I'm active in law enforcement, and I'm active as a pharmacist, people say to me, how did people get addicted to drugs? And I say, they got addicted to drugs, especially opioids, mostly because they're addicted to their own dopamine. They're addicted to their own neurotransmitter. The drug is just a vehicle to get them there. And that's why people can switch from one addiction to a different addiction and still have that same level of addiction, because they're addicted to the neurotransmitter, the reward mechanism in their brain. And so they'll ask me, okay, so how did we get here with opioids? And well, opioids are an easy way to get your dopamine. You take a dose of opioid, and there's a rush of dopamine in your brain. You feel a euphoric effect. You feel awesome. But it's also a slippery slope, because the more your brain releases dopamine, the more it holds back on the next dose. So you're constantly trying to get to that first feeling. And so all you can think of, the only mechanism to do that is to what? Take more and more and more and more and more frequently to try to get back to that original feeling. And that's what leads to the addiction.
I've never heard it put that way. But it makes sense what you said, like how you go from one to the other. Like you were drinking, now you're not drinking, now you're
gambling.
Now you're right.
Smoking.
All the things.
Yeah.
And if you dabble, and you'll hear this from people who don't understand addiction, that why can't you just have a drink? You're not an alcoholic. Like that wasn't your drug of choice. Why can't you just have a drink? But when you put it like that, that makes complete sense.
And it's all stuff that smart people have told me all my life. I'm just a good sponge. I just remember a lot of it, but this is all good stuff I've learned over the course of time. And I will say that opioids are no different. You take repeated doses to get that same feeling. But that leads to the whole problem of supply, because everyone's now saying, I'm not going to keep opioids in my house, and I'm not going to, I'm going to bring them to the police station twice a year and get rid of them. I don't want them in my house. Then where do people get their opioids? Diversion is the word they use. That's when you prescribe an opioid for someone and it gets used by somebody else. Okay, but if docs aren't prescribing and no one's got them in their home to divert them, then we're running out of opioids. Exactly. And that's why heroin is so popular in this country. Because heroin is the opioid. It's the synthetic opioid, and synthetic meaning you don't have to grow a poppy plant to make it. You can get it, you can make it directly, right? There's mechanisms to make synthetics like heroin, and even more impressive synthetics like other types of heroin that are available, and fentanyl. So people ask me, why is heroin so popular? And I say, because it's cheap, it's easy to get, and there's a line of people, a willing line of people ready to buy it, because they can't get their opioids anymore. So the progression from opioid analgesics to heroin is an easy step to take. Now, some people look at that and say, well, yeah, but that means we're not having an issue with opioid analgesics anymore. You're probably right. because people are just switching to heroin.
Moved on.
We've not fixed the problem. We just moved the problem from one agent to the other. And of course, we have less control over heroin than we do opioid analgesics. So I guess the issue that comes back to dentistry, if we want to tie this back together, is how did we get involved? I've heard it from enough people to make me want to, to make me get sick, which is, it's dentistry's fault. We started the whole process. It's the first dose of an opioid that a teenager gets is that prescription for an opioid after their first third molar extraction. And once they get a taste of that opioid, they're hooked, and it's a lifetime of addiction ahead of them. And I just say, they can get opioids from their orthopedic doc too if they sprain their knee.
Exactly my thought.
Yeah, I mean, the kids get their hands on opioids from a number of different avenues. It's not just dentistry. And again, I've never seen a dentist prescribe more than 20 dosage units of an opioid ever. When you've got other docs out there prescribing hundreds of Percocet and Vicodin, we're just a very small piece of this greater puzzle. But it's unfortunate to think that the more aggressive we are in treating the opioid analgesic addiction, the more we're driving people to heroin.
So the claim is that dentistry and the third molar extraction is the impetus to addiction.
Correct.
But, I mean, is there any stats to show that how often a child would go have a tonsillectomy or have their adenoids removed or, broken arm, broken leg?
Exactly.
Like, is that, how do you just, not see that part of life?
I don't, not to get political, but I believe a lot of it has to do with just where the low-hanging fruit. It's kind of easy to pick on dentistry. We're known for prescribing opioids. So if you want an opioid, where do you go? Go see the dentist and fake pain, and the doc will write you a prescription for opioids. Well, we're well past that. I mean, those days are long gone. But the public impression is still out there that we're the easy mark. It's easy for people to get opioids out of us. A lot of that's changed with the prescription drug monitoring programs that are available. Every state has one now, almost every state, I believe, almost all of them, where it's a database. That's what it's called in most places, just affectionately the database, and it's a repository of data. The pharmacies fill prescriptions all day for opioids and other controlled substances. They upload that information at night to the state, and the state puts it into a recognizable format. The next morning, it's there for every prescriber to see. You, me, whoever filled the prescription yesterday for Percocet. And it's a way for docs to be well informed as to, should I prescribe an opioid for this patient, or is this patient already on an opioid from somebody else? And it really has curtailed diversion, because why would I want to try to scam a dentist at this point when all the dentist has to do is have me at his or her desk, flip the computer screen around and show me the database and say, is this you? It sure looks like you. Looks like you've had prescriptions filled recently too. So it's pretty much done away with diversion. And again, while that's a good thing, I don't want to be the negative here, but it drives, again, people towards illicit sources of opioids because they're not listed in a database. So you've got heroin as the big opioid out there. But you've got a lot of people who abuse other prescription drugs to get an opioid-like effect. And the most abused prescription drug in this country right now that most people don't know about is a drug called gabapentin, Neurontin. Gabapentin was used often with opioids together, but since they were prescribed together to treat pain, and most people took more opioids than they should, they had all this extra gabapentin left over, and so they took massive doses of that in experimenting and found that it gave them an opioid-like high.
Really?
So gabapentin is very much abused in this country right now, more than most people think.
And what's the main, why are they being prescribed gabapentin?
Neuropathic pain, pain of unknown origin, lower back pain, that sort of thing.
Like fibromyalgia?
Yeah, fibromyalgia, or chronic intractable pain, where Neurontin, gabapentin, is a very good drug for blocking pain. That's the good news. The bad news is that taken in very high doses, it can give you that opioid-like effect. The most abused over-the-counter drug in the country right now, in many states, is Imodium.
What?
Yeah, Imodium, the poopy medicine. Yeah, Imodium, and that's because Imodium is an opioid. So most people take Imodium and don't realize it's an opioid because it doesn't cross the blood-brain barrier. It doesn't give them a high. It just gives them the constipation, which is what they're looking for. But if you take it in massive doses, it can cross the blood-brain barrier and you can get high on Imodium.
Who finds this stuff out? Like,
I don't want to be around when these people let loose, I'll tell you that much. But, yeah.
like, who was just like, let me just take a 12 Imodium. Oh, look there, I'm high. Like,
Yeah.
Well, it's probably someone who's like, I am so desperate it won't stop coming out. Like, I need to shut this valve off.
oh, look, I'm high.
Oh my gosh, this is the best.
I have diarrhea and I don't care. No, I think people just, they know the pharmacology. They know the mechanisms of actions of these things. So a little word gets out on the internet and it just explodes. Experiment with this, experiment with that. Imodium came from very modest roots, but recently the FDA, if you listen to Dr. Gottlieb, who runs the FDA, he'll tell you that he was just on there saying, telling manufacturers of generic Imodium to stop making it in big packages. Because kids would get a bottle of 100 Imodium and take that home, and they'd have enough supply. But now, if you only make it in small packages, you have to buy multiple packages to get that much, and it would sort of raise a red flag.
So eventually is Imodium going to be back there with Sudafed?
I think everything's going to be behind the pharmacy. You're going to have to walk in. There's going to be a counter because almost everything in some way or another gets abused. Yeah. It's pretty.
Well, that's what you see in like Latin America. Everything's like at a
you have to go
pharmacy
up to it and ask for it.
ask for it specifically, and then they give it to you that way.
That's a good point.
Yep.
I'm red flagged because I pretty much bought half of the decongestant aisle one time. I was like, I can't breathe. I'm dying. Here's my license. What else do you need?
And that's just the little segment of abused substances that are opioid-like. There's a vast array of other medications and over-the-counter substances that people use and abuse. Probably the most interesting thing I could say else, in addition to what we talked about, is that the issue of cannabis and how marijuana is looked at as the escape route from opioid addiction. That I can wean myself off opioids and wean myself onto cannabis and have a better control over that addiction than opioids. That's one avenue. The other avenue is we use drugs like Vivitrol and Suboxone to block opioid effects. But the bottom line is you still have to go through withdrawal to use Vivitrol or Suboxone. I mean, yes, sometimes we use Suboxone to help you through the withdrawal, but you still have to go through the withdrawal to get to where you can take Vivitrol and Suboxone as blockers, opioid blockers, to maintain your sobriety. People ask me this all the time. Don't we treat addiction? No, we really don't. We maintain your sobriety more than we treat the actual addiction. We get you through rehab and detox, and then we put you on a drug to maintain your sobriety going forward. So many people feel, well, that's a kind of a hard turn to take. It would be easier to just move into cannabis and marijuana. The point being that cannabis is viewed as, and this has changed over the course of time. I mean, it used to be called a gateway drug, and now cannabis is used is viewed as the kinder, friendlier herbal. That I can use cannabis, and there's much more information on it. It's not the same cannabis that was available 20 years ago. It's much more refined, and I can use it in different ways. I don't have to smoke a marijuana cigarette or a joint. I can use volatiles, I can use oils, I can use edibles. So there's other ways I can use marijuana to both treat pain and also ameliorate the symptoms of withdrawal, and maybe move myself from opioids to a marijuana platform to treat my pain and manage my addiction.
What is cannabis use? Is there any issues with our patients that we're seeing as far as pain management? Because you also, I haven't treated a lot of patients that were obvious addicted to cannabis.
I'm by Portland, so I've seen.
I was going to say, like, I'm in South Carolina where it's not legal, so.
Washington, Oregon's both legal.
It's like everywhere, right? Yeah. I'm pretty sure I was high on the train getting here in New York, though, because it was full-on cannabis action in there. Yeah. But when we're treating patients that are using cannabis, is there any pain management issue that we would run into?
Well, the first problem is recognizing if they're even on cannabis. With the advent of the oils and volatiles, there's really no way to tell. I mean, there's no smell. You don't smell anything. Right. and most people get it in by vaping it. So they use vape pens or jewels or whatever, and they sort of get the drug directly in their system. So there's no smell, there's no physical evidence. It's really hard to tell. Now, if they admit, yes, I'm using a cannabis product, I'd have to be a little more conservative in my use of anesthesia before I knew for sure how they would tolerate it. Because some people tolerate anesthesia better when they're using cannabis, and some not so well. The other thing is pain control. I mean, should I prescribe a regular dose of opioid for someone that I know is using cannabis, or would that cannabis product take the place of that opioid? Is that even ethical to rely on their use of cannabis to treat their pain when really they would probably need an opioid analgesic? Or is it ethical to prescribe that opioid analgesic if I know they're using cannabis? So it brings up a lot of ethical dilemmas that we don't have any answers to right now.
Are we talking about like a drug-drug interaction, or how they are going to react with the feelings that they're feeling on with different drugs?
I would say it's a more drug-drug interaction. That it would increase the central nervous system depression and potentially the respiratory depression you get from just the opioid alone. But again, we don't know a lot of this because cannabis is still Schedule 1. So it's considered illegal in this country. There's no pharmaceutical companies doing a lot of research on it. There are some. Recently, a CBD product was approved for the use of children's epilepsy. But overall, there's very little research being done, so we don't know.
Are you pro cannabis? This almost feels like that way, but I'm not really sure if you're.
I'm down the middle of the line because I'm more interested in the science of it. I know there's potential there, but I don't know. I don't know enough about it to be politically yes or no on it because I'm operating at a deficit of science. I don't know.
So for our patients, though, you're still kind of down the line. You're not really sure yet if it's pro or con.
There are those people out there right now that believe that cannabis should be used chairside. That we should be using cannabis in the office to ameliorate
Nitrous,
anxiety.
no more.
Yeah,
Hello,
forget
cannabis.
nitrous.
Plug in my
Plug in my jewel and
vape
the scavenger.
instead of nitrous hoses. Yeah.
There are those that's exactly right. They believe that we should use it chairside, whether it's the
edible.
oil or it doesn't matter, CBD oil or THC CBD oil, and use it to ameliorate anxiety and pain right there. But again, I think that's well down the road. I mean, I'm sure there'd be
a diffuser. We're gonna see. So the science isn't there for the U.S. because it's illegal. But what about other countries?
Canada's doing a lot of research on it,
Okay.
and so a lot of countries in Europe doing a lot of research on it. But the problem is we have access to the data, but we don't have access necessarily to the mechanisms that were used to derive that data. And so we were only looking at it retrospectively. What was the process done to get the data? What was the study like? In the United States, we feel much more comfortable when we're doing the research. And if we're going to get anywhere with cannabis in the United States, it's going to have to go through some type of FDA approval process, and that's going to require descheduling it. So,
Get on it, government.
This has been great. I mean, we're out of time, but I really appreciate you being.
This is amazing.
You know what I didn't lead in with? I was gonna lead in. I was thinking about it on the way over, and so I went over and saw the room that Tom was in, and he had the AV guy coming up and talking to him about osteoarthritis and what kind of medications he used. He was listening the whole time, and he said that was one of the best presentations. A non-dental, an AV person from this conference.
This is very, very understandable information. Like you're really putting it in a way
really
that
relatable.
makes sense.
And I love this.
I just had the same experience at my morning session. The armed guard who was standing outside the room came up to me and said, I learned more in your course than I ever learned ever, and I'm so glad I was stationed outside your course. And I'm like, well, that's nice. I made the lady with the gun very happy, so I'm good.
You're safe. That's good.
She's
you
happy.
Will be protected. She'll find you
That's right.
in the incidents of the need for protection.
Yeah. And also one other thing, too, is your website is amazing. For all of the speakers that we've looked up,
Yeah.
yours is
Who
so
wants to
comprehensive.
do mine? You want to send that over?
Yeah, you want to do
Who
our,
wants to, want mine next?
So maybe you can give some contact information for our listeners, and they can go on to your website and see what courses you're giving, because they're going to want to come find you.
Yeah, it's tomviola.com. It's as simple as you can get. I've designed my website to be as easy to navigate as possible. I want it there for both people who want to take webinars and who want to take any kind of course that I'm offering either live or online. But I also made it easy for meeting planners to get on there and find me and hire me to speak. So I plan on doing more blogging and more social media probably this year. I just need to convince my daughter to teach me how to do it. So that's the hard part. But hopefully
that's
I'll
kind of
get there.
my gig these days, the social media.
Oh, really? Okay, you could teach me then, because I have no idea what I'm doing. But got all the accounts set up. I just don't know what to do with it all. So find me at tomviola.com, and it's Pharmacology Declassified. That's the sort of the name of the company that I've developed over the course of
How
time.
many courses do you teach? Different, or how many topics, I guess?
I have
are
15 different topics that I
So
teach.
there is
Yeah.
plenty for you guys to listen to and have them back again and again.
Yeah.
Plenty of information out there.
So,
Yeah.
all right, Tom, we
Awesome.
really appreciate this.
Yeah.
Thank you for
so
having me.
much.
This is great. Thank you. I'm looking forward to more. Thank you. It's great.
We hope you enjoyed this episode powered by Crest Oral-B, and be sure to check out the show notes and click the link to get your CE credits for this course. Also, you can check out dentalcare.com for more on-demand CE courses.
And to listen to more great episodes from us, you can go to ataleoftwohygienists.com. You are welcome to send us emails with feedbacks and questions, comments at ataleoftwohygienist@gmail.com. And you can always find us on any of the social media like Facebook and Instagram. And we welcome all direct messages and sharing of all the episodes.
Be sure to stay tuned for more bonus episodes powered each month by Crest Oral-B.
Anything else, Andrew?
I think that's it. Have a good week, everyone.
Bye, y'all.
Bye.